Assalamu alaikum warahmatullah. Welcome everyone on board. Um, because some of the people I can see were there tomorrow, yesterday as well. So I will I would just like to tell that yesterday when we were discussing the topic about pain, actually I forgot to mention about dexamethasone. So dexamethasone is also part of regime for multimodal analgesia, and surprisingly, people forget and they use it for post-operative nausea vomiting. They say that it is to reduce the inflammation after endotracheal intubation. They give it for like avoiding of any edema, but they forget that it's an anti-inflammatory medication otherwise. And even if you are giving some intra-articular injections or even nerve blocks, it increases the duration of action. Okay. So actually yesterday, after I finished, one of the colleague just messaged me, and I'm thankful to that person to just remind me. Um, so today, uh, actually, everyone, again, I repeat one thing that I'm just trying to, because restarted after a while. So my basic purpose was to um, give an like a basic idea about a number of things which are needed daily in the daily practice. Okay, so we started from preoperative anesthesia assessment, chalking out risk factors. We discussed some of the investigations. Then we discussed some basic principles about about complications. Yesterday we discussed a basic plan about analgesia. Okay, so today we will just try to have a look on how to monitor a patient. Okay, generally we use the word standard one and standard two. Can we discussed before as well. What is the basic purpose? Can anyone tell that what is the basic purpose of monitoring a patient? Yes, Yes, anyone please? Abdul Rafe, would you like to speak up?
Yes. Sir, to ensure the safety of the patient,
Yes, okay. Ensure the safety of the patient. What else?
For a rapid response and action for any deterioration.
Very good. Like anticipation of
Yeah.
any
Anticipate something wrong will happen.
impending problem. Okay. So actually,
Yeah.
uh, uh, this is the basic thing. Actually, these are the aspects which are actually covered by the anesthetist. But actually, when we are monitoring the patient, sometimes there are something which are related to surgery. But actually, uh, we are like when we go a little deep, you will find that their monitoring is a little beyond these things. Okay, so if we talk about these things, actually, this will be safety will be with the standard one and standard two. Okay, standard one and standard two. What we know about it as like everyone know about it as SpO2 and temperature, CG, okay, and blood pressure. So, like if we just go a little deeper into it, the what other monitoring you think can be used? If we can just make a list, and then we will just try to have a look on one by one, like urine output. Okay, there is neuromonitoring. Okay, then neuromuscular monitoring. Okay, then ICP monitoring. This is also somehow related to neuromonitoring, but ICP monitoring. Then, if we just broader, maybe you can say perfusion of vital organs. Which vital organs perfusion we can monitor? This is a little
Kidney.
different. Very good. How can we monitor? It actually, this
by
is the urine output.
Intra-abdominal
yeah, by
pressure.
Also intra-abdominal pressure, you can say. Okay, but actually it is urine output. If you want to indirectly know the kidney is perfused, you can monitor it through urine output. Then if you want to see brain perfusion, again I'm just giving you a little atypical thinking, how can you monitor the brain is perfused nicely?
By
by
measuring ICP.
ICP and
Okay,
central venous pressure as well.
I'm sorry, I cannot hear you. Please say it again.
Central venous pressure as well can
Central.
indicate the brain perfusion.
Okay. Somehow, CVP. What else?
Blood pressure.
Okay. So, the better with the both actually CVP and ICP, the better word is cerebral perfusion pressure. Okay.
Yes.
So how can we indirectly monitor cerebral perfusion pressure?
By subtracting ICP from map.
That is yes. This is the exact formula. But usually indirectly we can see with the BIS. Okay. Entropy. Okay. What else? BIS entropy are actually, and actually more accurately, EEG. Okay. So whenever we are monitoring the cerebral perfusion pressure, there are two concepts. One is global and one is focal. So like in majority of the things which we are doing, we can measure because this is BIS and entropy is processed EEG. But the original, I think 12 lead EEG, what is the word? Because I have never used it, so I cannot comment about it. There is a separate department. It's like separate people who are using as a whole, not only EEG, they are using this like proper EEG with BIS, then somatosensory evoked potential, motor evoked potential. Okay. So the as a whole package, usually there is a dedicated, not every, it is not available in all setups and all hospitals, neuro monitoring. Okay. And also use the word neurophysiological monitoring. Okay. Some other monitoring which we do with reference to neuro is if especially this is important when we are doing carotid endarterectomy, that is stump pressure. Okay, stump pressure is measured. Then transcranial Doppler. Okay, transcranial Doppler. Carotid ultrasound indirectly can tell you about monitoring the neurophysiology and neuro.
Right, ये स्कूल में किया alhamdulillah.
Yes, near infrared. Actually, I am very short of concept about near infrared spectrometry. Can anyone highlight, please? If you otherwise, I will bypass, and because we are just touching at the moment, and inshallah, I will just try to have detail. Tayyaba, can if you have concept, can you speak out few words about near infrared spectrometry? If not, okay, no problem. Okay. Then actually, then another thing which is there is uh, jugular venous saturation. So anyways, these are like some of the detailed concepts about neurophysiology and neurophysiology monitoring. Okay. At the end of the surgery, of course, we will have certain thing with we said about ICP. So ICP usually will be monitored with clinical sign symptoms. Not really in every case we are monitoring ICP. If we want to measure the ICP, actually they either it will be epidural bolt or ventricular bolt by which we can actually measure or transduce. But usually the clinical sign symptoms will tell you about this thing. Okay. So coming back here, So we just say that vital organs, we just try to have a look on brain and kidney. Okay. How can we monitor the blood supply of heart? What will tell you that the blood supply of heart? Yes, were these examples of
Sir,
yes,
the
Heart
device
rate.
ECG. Okay. So ECG, if any problem will occur with reference to ischemia, there will be either like ST segment depression or elevation or some arrhythmias can occur, especially if it is related to like conducting system of heart, there may be bradyarrhythmias. Okay, so like if you want to because this concept is not written as such, but I'm just giving you a concept how to monitor the vital organs, because this is how you should be knowing about your vital organ. Okay, so this is actually the same thing but with a different mindset. So ECG will tell you a lot of things. Okay, then what else other than ECG? Echo, especially trans esophageal echo, because even it will tell you like very sensitive about the segmental wall motion abnormalities. Okay, segmental wall motion abnormalities will be picked with the echo. Okay, again, if you want to, because there the second thing for monitoring this thing will be point of care testings. So actually this is not purely monitoring, but actually point of care testing can tell you further about the perfume. Point of care testing with reference to heart will be enzymes. Okay, CKMB, CPK, or TROP-I, TROP-T. This will be the next step towards the monitoring of heart. Okay, when how to monitor spinal cord? Again, this is actually related with the same neurophysiology which we discussed. And whenever there is any problem with the integrity of spinal cord, there will be changes in somatosensory evoked potential and motor evoked potentials. So that's why whenever they are monitoring the spinal cord, you have to avoid any medications which are affecting the the latency. There are two concepts. One is latency and one is amplitude. Okay. So if you are trying to provoke someone, in how much time he is replying to you is the latency, and how strong he reply is amplitude. Okay, so this is just a concept with reference to wake potentials, latency and amplitude. So you have to consider the medications which can that. So and as a general concept, usually we are using tiva, and whenever, because I have conducted a number of surgeries in which they are doing neurophysiology monitoring with reference to not only neurosurgery, spine surgery, with reference to this scoliosis surgery. So in which they are, because once upon a time there was a terrible test which alhamdulillah I never saw, and I don't want to say saw in my life, is the uh, this wake up test. So before, the monitoring for the integrity of the descending and ascending tracks was wake terrible, horrifying wake up test. So in the exam they will ask you, but practically nobody is doing it unless it's not available. The neuro monitoring is not available. Okay, what about intestines? Is there any test or anything by which you can monitor the perfusion of intestine?
Sir, again, intra-abdominal pressure.
Intra-abdominal pressure. Okay, there is another thing, lactate. Okay,
Okay.
usually lactate will go up if you are doing because ABGs as a point of care testing gives you a lot of information, not only cardiovascular system, respiratory system, and ischemia. Okay, sepsis. So like electrolytes. So actually ABGs is not only for respiratory system, because we only think about PO2 and PCO2, but it is beyond a lot of things. So lactate levels are there always, serum electrolytes are there, calcium, potassium, sodium, and lactate. So like it is telling you overall perfusion and lactate. If you are, of course, you will be suspecting in specific scenarios. So like if the patient is on high dose of vasopressors, then you will be looking into these things. But overall, and now someone just to bring people in attention that these questions will be asked in different ways. They are discussing a scenario of sepsis, and they would be expecting that you should be knowing that if you want to see the gut perfusion, what investigation or what thing will tell you that the gut is not perfused nicely, that is lactate. Similarly, if you have a case in which the heart is under pressure, so heart is under pressure in which condition? For example, there is hypertension, there is ischemic heart disease, there is high risk surgery, patient suddenly bleed, there is no hemoglobin. Now if you want to know, if you want to tell, I would be, how would you monitoring the heart? So the first answer will be ECG, the other answer will be echo, for example. And there are certain other things like, as I told you, enzymes, other cardiac output monitors, and CVP, like this one, mixed venous oxygen saturation. There will be so many things which will be telling you the situation of the heart and situation of the perfusion of vital organs. So this is just a concept for you people to how to monitor, other than, because SpO2 and tidal CO2, blood pressure, intraarterial blood pressure monitoring, you all know. Okay. And of course, this is at the moment, my domain is not to tell you in details, or I will tell you one thing just at this moment, that whenever you are reading any monitoring, so what things you should know. Okay. Especially this point is for the juniors who are preparing, or anyone who is preparing for basic science exam. The basic thing which you should be knowing is what is the working principle. This is true for almost all uh, this one monitoring equipments, monitoring things. What is working principle? There will be some, like for example, working principle of SpO2 is Beer-Lambert law and plethysmography and oximetry. So this is the working principle, and how it is used, that like they are combining plethysmography and oximetry, and oximetry, there is Beer law and Lambert law. So like this is in how that you have to explain about working principle, how to use it, and how to interpret it. Okay. Then what are the limitations? Like every monitoring equipment will have some limitation. So limitation, or you can say errors, and how to do the troubleshooting. Okay. So this is usually for, and different types, and how to use it actually. Before that, you will need to have how many different types. So maybe, for example, with reference to end-tidal CO2, when there is one side stream, there is mainstream, the working principle is infrared. Okay. And there are different phases of it. Similarly is true for pulse oximeter. And if you just bring this, rather than, the advantage will be that when you are reading that monitoring from any book, instead of just cramming the words written, you will try to find out the answer, because in the exam they will be asking you these things, types, and you can say equipment type, oh sorry, equipment parts. Okay. So they will be asking you in majority cases about any monitoring equipment. These are the questions which you should be knowing. What is the working principle, how to use it, how to interpret the data, what is the troubleshooting, how to interpret and anticipate and react, you can say. Like if pulse oximeter graph is not coming, it means few things. Either the patient is cold, perfusion is not there, either the pulse oximeter is not placed right nicely, either the probe is not good. Because if the waveform is not coming, actually whatever reading it is, whether it is 100%, whether it is 80%, it is not reliable. Okay. So this is how you will anticipate what you will do, what will you react. Okay. So this is the basic thing you should be knowing about the monitoring. Okay. So uh, just I will just show you one thing. Actually, this is the latest guideline. I will come back if I, because my mind is just off at the moment. I will just try to, this is actually new I just saw actually just now. This is the latest AAGBI guidelines, Association of Anesthetists, Great Britain, Ireland. So you see the presence, adequate supervision. This is, you can say, anesthesia, standard one monitoring, then ECG, SpO2, NIBP, capnography. Okay, and yes, another point which I want to tell, that this monitoring standard of standard one, standard two is there everywhere, uh, up to post-op. Okay, up to post-op. Actually, usually not in all hospitals there is a doctor in post-operative care, but actually, ideally, it should not be monitored by nurses alone. It should be monitored by anesthetist, ideally. But in majority hospitals, unfortunately, it's not there. But actually, the standard of care, then the same standard of care of there is there. Either you are performing monitored anesthesia care, even local anesthesia. You need to have that standard one, standard two monitoring. You should be there. Okay. So you are providing it with reference to GA, recovery, PACU during transfer. Okay, this is very important. If you are transferring a patient and, for example, that patient was above standard one, standard two monitoring. Actually, if the transfer during the transfer you are having any doubt that the patient can decompensate, or so you need to continue. Like you can have the arterial, even arterial transducer attached. Especially this is true in the patients who are transferring from the anesthesia unit to the ICU. Okay, even maybe you can monitor arterial blood pressure in the PACU. So you need to have the same standard, and these are actually sideways monitoring standards. Okay, then whenever you are transferring, not only you need to have the monitoring, you need to have the equipment or the things which are there for the resuscitation, because you are monitoring not for the sake of monitoring. You are monitoring with for the sake of anticipation, and for anticipation you need something. So for that thing, generally there is this, because this is a big topic, the patient transfer. Patient transfer may be from OR to PACU, maybe from OR to ICU, maybe from one hospital to other hospital, one city to other city, one country to other country. There are like so many things: air transfer, car transfer, like, sorry, ambulance transfer. But you should be knowing the basic concept. Generally, the double the time for, if it is oxygen dependent, even if it is not oxygen, but whatever oxygen, usual oxygen requirement is there, you need to have the double oxygen source. So this is the basic concept. Okay. Then we did not touch about neuromuscular monitoring. Neuromuscular monitoring, especially in cases in which anything which can prolong the effect. Number one, this will be one reason for neuromuscular monitoring. The other reason is that you don't want the patient to move. Okay, so that will be usually two indications in which you need to have strict neuromuscular monitoring, like for example, eye surgery or any delicate surgery in which you don't want the patient to move. So in that case, you will be monitoring the neuromuscular blocking, especially like, you can. This is another topic, how to monitor. You can usually, it's train of four, or if you want strict monitoring, PTC count. Okay, usually PTC count is for strict monitoring. Okay, we discussed these points about process EEG with reference to TIVA and TCI. Okay. Okay, some other point of, actually these are point of care testings with reference to capillary blood sugar, glucose, ketone. What are the point of care testing? There's few words about point of care testing, because this is a growing topic and you will be asked about it. One of them is ABGs, urine dipstick test. Urine dipstick test for not only for ketones, for proteins. Okay, so like these will be the dipstick test. Sugar, blood sugar. What else? Like coagulation tests. Usually ACT, INR, APTT, like they are measuring either ACT or INR usually. Okay, then ROTAM or TAG. So you should have a good concept about point of care testing. Got point of care testing. Like even indirectly, there are monitors which are actually telling you the hemoglobin level. Hemoglobin Massimo monitors are there in which they are telling you an idea about non-invasively they are measuring the hemoglobin, and it is telling you. Then another very important component of monitoring is alarm. Very, very important. Actually, this is something I did not mention. Usually, when alarm is buzzing you, disturbing you, a number of times you just switch off the monitor, switch off the alarm. But actually, this is not the solution. You should be knowing what is happening. Because and another thing is that you should set the alarms according to the patient requirement. Okay. So because if you don't set it uh, according to the requirement, maybe it will be just calling you out of context, and maybe if it is the real problem is there, you have already mute the monitor. So this is something very, very important. Record keeping, of course, record keeping is very important with reference to medical legal, and also for example, if you hand over patient from one anesthetist to other anesthetist, it's very important. Okay. And of course, medical legally, and for the better and for research. If you are not keeping the record, yes, in major like still in majority of hospitals it's handwritten, but a number of hospitals they have converted all the data into computerized system. Okay. So as I told you here, blood gases, hemoglobin, flexible bronchoscopy. Yes, very good. This is another point we should be knowing. In which conditions you will be using bronchoscopy? Monitoring CSF pressure during general anesthesia. CSF pressure we measure with the epidural bolt, and we just transduce it. It's the same principle. Okay, nothing special. Difficult airway? No, we are talking about use of flexible bronchoscopy to monitor. So use of flexible bronchoscopy.
So for double tube placement
Yes,
or
yes. Okay.
confirmation.
Confirmation of or handling of double lumen tube. Okay. Because for that you need to have flexible bronchoscope. Or there is another very now you see when you think you you recall a number of strange things. Like if, for example, you were doing a laser, airway laser, and there was airway fire. Even for that thing you will use flexible bronchoscopy as a monitoring tool. You have to do you have to see after any, because I have the honors to see uh, twice airway fire by the same surgeon in the same hospital, which I never saw before 18 years. And in 1 year I saw two times with that surgeon. And after that I was so terrified by that surgeon that actually I developed apneic technique. I used to disconnect the circuit when he used to use the laser, and I used to say, please, I will connect the oxygen when the patient is getting hypoxic. So actually this is one of the factors. So you can make your own mind, think about it, and you will find there are so many things which you will develop when you think. If you just try to read only the books, you will never be able to um, okay, now it is just here. If you have given a regional anesthesia, spinal or epidural, and or you have even have put just I give you a scenario. The eye surgery is going on, okay, and you have attached the pulse oximeter, and now you have put oxygen with the cannula. You still can do one thing, that you can attach the probe the probe for the end-tidal CO2. Like you can just attach. There are specific nasal cannulas in which it is built in. Okay, so they are telling you the beat the breathing. Okay, it are they are telling you the yes, examine airway. Okay, so like it will tell you, because why it is important. Can anyone tell why it is important pulse oximeter rather than pulse oximeter? Because you have put pulse oximeter, patient is breathing spontaneously. Why you still want to have end-tidal CO2? Can anyone tell? Yes, Abdul Rafi. No, no. This is with refer tube detachment is there. I'm talking about a different scenario. Okay, actually, if for example, patient has become apneic, you have put a sheet on the patient. Patient has become apneic, and you don't know. Okay, if you have end-tidal CO2 monitor, it will immediately tell you that patient has become apneic. Okay, or even if patient is gradually not breathing well, you will get to know. Pulse oximeter will lag behind because saturation will come down late. Okay, so that's why end-tidal CO2 monitoring is very important. Okay, so this is something I hope you understand. This message is especially for the juniors. But like if you can, even if you have put oxygen mask, just attach the, if you have the facility of end-tidal CO2, of course, this is standard of care, but I know that still there are hospitals where end-tidal CO2 is not available, but you disconnect the end-tidal CO2 attachment, and you can put it just inside the face mask, and it will tell you. Okay, so just make a habit of using it whenever it is available. Okay, fatigue vigilance, of course, if you have an anesthetist after 30 hours duty, you will have double vision, and of course it will not be safe. Okay, human errors are always there. Another thing, very important thing, which is not directly here, is the drug errors, medication errors, like with reference to blood transfusion. Actually, it also comes in monitoring. You should be knowing how to confirm the correct blood. You it's important how to fill the ampules. Ideally, there should be standard concentrations and standard syringes in the hospital. In a specific department, it is better just make a standard that everyone knows that these medications are prepared in 10 cc and everyone is using like that same concentration. It is better. Then labeling with the name, and it is better to use capital letters, because if you are writing in African language, not nothing to take away for with reference to African, but actually, if you are writing in any language we don't understand, Chinese or African or whatever, usually when you write with the small letters, you don't understand even after some time yourself. So it is better to use. And actually, there is a standard of color coding. Like for example, give you an example that usually red color is for muscle relaxants, yellow color is for induction agents, green color is for reversal agents. Like there is a standard color coding, and actually this can also be asked in your OSCE exam and in oral, even in oral exam. Okay. Yes, very good point, Mehdi. That these monitors are just to help you out, because the point which Mehdi raised is monitors are just to, to support you. The physical touch of the patient with reference to checking the pulse, checking the temperature, sweating or not sweating, okay, and also chest rise, and you can have a look from the circuit, okay, from the circuit and then going forward. Okay, another very important thing actually now because I'm telling you extempore, so I'm bound to miss some points if I don't remember. So please don't hesitate to remind me, because the very important thing is actually monitoring with reference to airway. When I saw circuit, so there is actually the airway pressures, very important. Then another important thing is MAC, monitored this minimum alveolar, because there are monitors with MAC and agent analyzer. Okay, because this is like if you have machines like that in which you are monitoring the agent analyzer, you can give low flow anesthesia, because without it you cannot give low flow anesthesia. And actually low flow anesthesia, because unfortunately majority of people are afraid of using it, but if you have good agent analyzer in which you are measuring the end-tidal CO2, inspiratory CO2, okay, and tidal O2, you can use it. So usually 0.5 liter is enough for conducting a safe anesthesia. But condition should have this concept of low flow anesthesia. Actually, this is one of my to do things, and this is one of the things which I have adapted in like last few years, and I'm doing it and I'm enjoying it because there are so many advantages of low flow anesthesia. You are saving money, you are saving the environment, and you are humidifying the circuit more than usually. If you are using a flow of 4 liters, actually 5 liters, actually soda lime is sleeping. It's not working, it's bypassed, and you are giving dry gases. Like, okay. And if you are using low flow anesthesia, but for low flow anesthesia, should have a very good agent analyzer. You should have a soda lime, which is functional, and you should have the monitoring of the inspired and expired and calculation of MAC value. Because in the monitors, you put the age and it will tell you, reflect you a rough idea, of course, not 100%, but you can have a trend. And one thing I will just tell you about low flow anesthesia. Remember one thing, because the gases are recirculated again and again, again and again. So any change in either direction, I repeat the word, any change in either direction, like for example, you want to increase the depth of anesthesia, only increasing the dial will not increase the depth of anesthesia immediately. If you want to change immediately, not only you need to increase the dial, you need to increase the flow as well till you achieve that MAC level. Similarly, your patient becomes hypotensive, and now you want to decrease the depth of anesthesia. So only decreasing the or closing the sevoflurane will not reverse it immediately. Okay, you need to increase the flow again. Okay, I hope you understand. In low flow anesthesia, if you want to achieve any change in the depth of anesthesia in either direction, you cannot achieve it by only changing the dial. You need to increase the flow as well. I hope you understand. Okay, so this is a very important part with reference to low flow anesthesia. Okay, emergencies, fatigue, vigilance, cardiopulmonary bypass. They are when they are doing it, anesthesia record, monitoring. Actually, this is a whole of the detail, inspired, expired oxygen, as I was telling you, wave of capnography. Yes, very good. You see, I am forgetting. It's very good when we oxygen supply sources with reference to central supply, with reference to emergency cylinder. Even if you have millions of liters of oxygen outside, please, there is no replacement for two things. Number one, whenever you enter in the operation theater, please look at the ambu bag. There is no replacement for ambu bag. Okay, even if your word anesthesia comes, you have to have an ambu bag in your arm's distance, not in the other room. It should be in your at your arm's distance. Number one. Number two, emergency oxygen cylinder. Okay, because usually people, even anesthesia technicians, they never check. So you should check yourself. Anesthesia emergency cylinder, it should be there. Similarly, this one central supply, of course, there are a mechanism to check the central supply pressure, tug test. Of course, these are other things, but usually you have to do this thing. Of course, circuit checking the circuit integrity will tell you. Okay, and there are so many other things which you should be doing it, but this is the basic text you should be knowing. And of course, oxygen supply with reference to, as I told you, emergency cylinder, ambu bag, central supply, agent analyzer. Okay, these are the things which you can monitor. Okay, then we have inspired nitrous oxide concentration, inspired and end-tidal inhalational agents, as I was telling you. Okay, airway pressure, tidal volume, respiratory rate. Okay, quantitative neuromuscular monitoring, EEG, infusion devices, very important. Okay, infusion devices, why they are important? Because um, like if you are in using them without any sense, it should be properly labeled, the concentration should be labeled, the weight of the patient should be entered correctly, concentration, and then whatever medication you are giving. A safety check for you is that there is an option of volume to be infused, VTBI, in every pump, almost every pump. My suggestion is that as a beginner, if you don't know much about the pump, or you are prone to have a mistake, it is better to put a very low value of volume to be infused. so that after some time when that volume will finish, immediately it will buzz and it will awake you. Okay, like you will not give a medication uncontrolled. I remember, I will share with you, because when I was new to using syringe pump, one day I did a mistake. Usually majority of the medication which we are using are microgram per kg per minute. Okay, like remifentanil or propofol or a number of medication. Fentanyl is another way, it is microgram per kg per hour. So what happened, by mistake, instead of hour I put minute, and you will you believe, it went very quickly, and the syringe was finished. Of course, nothing happened bad to the patient, but I'm just telling you that if you set a low volume to be infused, it is a actually sort of protection. Okay. Then, and I have seen people, old consultants, they used to twist my neck for changing the number, the of like in, because in cardiac surgeries or in many surgeries there are a number of infusions: epinephrine, norepinephrine, muscle relaxant, and tiva, and this, and so they are so messy in that, actually, but I don't say anything bad about them, because actually they have faced some complications and they don't want to change their mind. But even they have set pattern: number one will be epinephrine, number two will be norepinephrine, number three will be dopamine, number four will be dobutamine. So even they are so worried about this thing. Another important thing which I had missed is cuff pressures. Okay, if you are using increasing the flow to reflect the change in mac, Tayyaba, I will explain, just give me few minutes. uh, just a second, please mute the mic, it's a disturbance for me. Anyways, so this is very important. Tracheal tube pressures, cuff pressures, there are specific pressure measurement by which actually the respiratory therapists, they have this equipment by which they measure the endotracheal cuff pressures. Then another, the same pressure is for if you have you are infusing a syringe pump for even you are starting to give the dose in peripheral nerve blocks. uh, if you are monitoring the pressure, you can avoid intraneural injections. I don't remember, I forgot the number. I think it is 15 or 10 PSIG. Please just check it out. How much is the syringe pressure you need? Of course, I have never used it, so I forgot. But I repeat, there is a specific pressure number which you need to monitor when you are injecting a medication. Okay. Especially in the nerve block, to avoid intraneural. I will just quickly repeat for Tayyiba. Listen, when you have a low flow anesthesia, nothing is going out, everything is recirculating. Okay, so only if you increase the dial concentration, because the flow, you need a specific flow to take the gas, carrier gas. Okay, so if the flow is very low, it will take a lot of time to get the new equilibrium. Okay, so that is the reason. Similarly, if you want to decrease the depth, if you don't increase the flow, because even if you have closed, because nothing is going out, everything is being circulated. So it will take a lot of time for its effect to to wean off. So in that scenario, you need to increase the flow. So that is, if you still don't understand, let just drop me a message. I will explain to you further. Okay, so monitoring the airway, cuff pressures, pressure volume monitoring. Okay, spirometry. There are the graphs which are coming on the monitor during endotracheal intubation waveform. Okay, I think I have given you an idea about what monitoring is. Okay, if anything missed, walaikum assalam. Yes.
Sir, esophageal stethoscope monitoring for quick surgery.
Esophageal. I'm sorry. What did you say again, please?
Esophageal stethoscope.
Esophageal stethoscope. Yes, it is for pediatric anesthesia. I have never used it. I'm sorry, I don't have much idea about it. But usually, it is more reliable in pediatrics, neonates. Okay. So thank you very much, all of you, and we will come back with some new topic, inshallah. If I will share this document to all of you, and you can have a look. Okay, but remember one thing: this topic may not be asked in the way I have told you. But remember one thing: all anesthesia, conduct of anesthesia is monitoring. If you can, if you can anticipate the problems, you will save your patient. If you don't know, you cannot save. Okay. So thank you very much. Inshallah, we will come back with some new topic tomorrow. Inshallah. Salam alaikum.